This is one of the first abstract paper where I will presenting. This is published in JCO this year. Prognostic value of stromal tumor infiltrating lymphocytes in young TNBCs, those who were node negative. So increased tumor infiltrating in lymphocytes have been associated with favorable prognosis that is already known, but below 40 years and early staged node negative, this study is about them. So it's data from retrospective data from Netherlands, and the study period was 1989 to 2000. So the pathologists were blinded to the clinical data, and STILS were evaluated and grouped into three categories: less than 30%, 30 to 75%, and more than 75%. Tumors were also analyzed for BRCA1. This is the three categories that you can see: 230 patients in less than 30% and 94 patients in more than 75%. As you can see, the results according to the higher the STILS, the survival is better in all patients. If you see various categories of T1 and T2, T3, the curves are widely separated. If you see according to STILS, they have separated different categories on the ultra low and high, and even then the category, all the curves are widely separated. So the conclusion was, it confirms the importance of STILS as a valuable addition to the set of standard prognostic criteria in TNBC. In young TNBCs, node negative, more than 75% STILS have an excellent prognosis. Data could be a starting point for a randomized trial of de-escalation of chemotherapy. STIL seems to be a promising biomarker in the area of NSCT for TNBC. Its role is undefined. De-escalation of chemotherapy directed by STILS is an exciting option. This is the second abstract. It is ZNF689 deficiency promotes intratumoral heterogeneity and resistance to immune checkpoint blockade in triple negative breast cancer. It was presented in SABCS this year. So we all know that intratumor heterogeneity is a significant challenge for TNBC. It has been a major obstacle to immune checkpoint blockade treatment, and there is not much data on this characteristic of TNBC. So what the investigator did was they took two subsets, one from the Chinese, the investigators are from China, and they have taken these two subsets of 260 patients and another 135 patients from TCGA, and they have tried to see the genetic heterogeneity and histological heterogeneity. If you see the results, the genetic heterogeneity and histologic intratumoral heterogeneity both are making a significant difference in the survival. So high tumor heterogeneity leads to a lower survival. Once there is a depletion of ZNF689, it promotes heterogeneity, and its genetic and histological both, as the investigators has shown in murine models. It also sensitizes to immune checkpoint blockade. So the conclusion was, it is desirable to establish a comprehensive landscape of intratumoral heterogeneity. ZNF689 deficiency promotes this heterogeneity through depressing line 1 retrotransposition, and targeting this heterogeneity with line 1 inhibitors can combat resistance to immune checkpoint blockade in TNBC. This is the third abstract, presented at ASCO this year, and this is Imprint immune signature to identify patients with high risk early breast cancer who may benefit from PD-1 checkpoint inhibition in I-SPY2. There is a remarkable increase of novel immuno-oncology drug in many malignancies had led to the need of biomarkers to identify who would benefit. The I-SPY2 consortium qualified several expression-based immune biology related signatures that predict response to PD-1 checkpoint inhibition. So investigators took early breast cancer biopsies of 69 HER2 negative patients who received pembrolizumab, they took it as a discovery set, and 70 such patients, HER2 negative patients, on durvalumab olaparib arm as validation set. So, those patients, the genes were identified, were predicted for PCR, then the effect size was to be more than 0.45. And the data was compared between PCR and non-PCR patients. If you see in HER2, the total 12 patients in HER2, hormone positive, HER2 negative had PCR in discovery set. If you see the ROC curves, in the discovery set, this Imprint, the discovery set they have a sensitivity of 100% and 70% sensitivity and specificity of 70%. In hormone positive HER2 negative, it is 83% and 85%. Positive predictive value is 77%. Similar is the finding in validation set. If you see the Imprint, this also tried to define the type of genes involved, and they found that these genes are all the known genes which are involved in immune response related functions. If you see, its prevalence on 1463 I-SPICE to patients, so majority of triple negative is immune positive. So it predicts, Imprint predicts PathCR in PD-L1 when they were treated with immune checkpoint inhibitors with high sensitivity and specificity. Over 90% of Imprint genes have known immune response related functions. Imprint also identifies tumor with an immune active phenotype denoted by the enrichment of several immune related pathways. It's very effective in identifying a subset of hormone positive HER2 negative patient who could benefit from immunotherapy. Data is exciting but small and hypothesis generating, needs external validation in independent data sets. This is another abstract that was presented at ESMO. Estradiol represses anti-tumoral immune response to promote progression of AR negative breast mets. So younger patients have increased risk of brain mets. There is an intrinsic role of estrogen in these patients. In TNBC, incidence of brain mets higher in premenopausal women compared to postmenopausal women. Premenopausal hormones like estradiol may promote brain mets by exerting effects on the microenvironment. So E2, that estradiol promotes brain mets, it acts through a paracrine action on ER positive astrocytes. In TNBCs, in premenopausal women, it promotes brain metastatic colonization, as has been seen this by the investigators in murine models. If you suppress E2 and add irradiation, it decreases brain mets progression in immunocompetent models of ER negative breast cancers. Alone estradiol is not making any difference. In immunocompromised mice, neither E2 nor in combination of radiation or without radiation is making any difference. Although estradiol suppression activates immune surveillance at early stages of brain colonization, and this suppression also recruits T and B cells of the brain at later stages of metastatic progression. So, can E2 suppression synergize with anti-PD-L inhibitors? So, investigators could not find there is any synergy. They concluded E2 depletion might be used in combination with radiation therapy to decrease brain mets in younger women with TNBC. E2 depletion therapies reactivate an anti-tumoral immune response, including increased recruitment of T and B cells. Clinical studies in human subjects are warranted. Role in combination with immunotherapies need more data. This is another plasma match trial cohort E analysis. This is a phase 2 trial of olaparib and ceralasertib in TNBC patients. So plasma match trial was an open label platform trial consisting of circulating tumor DNA in around 1,000 patients with advanced breast cancer. There were multiple cohorts. In that, the data of multiple cohorts have already been reported in Lancet paper, but this is data of cohort E that recruited patients with triple negative breast cancer without a targetable mutation identified at ctDNA screening. And they were treated with olaparib and ceralasertib, that is ATR inhibitor. So they were post 1 line or 2 lines. Olaparib was 300 BD continuously and ceralasertib was 160 milligram per day, day 1 to day 7, every 28-day cycle until disease progression, and the primary endpoint was ORR and second endpoint was clinical benefit rate and PFS. BRCA and somatic DNA repair gene status and ATM loss was also investigated. So around 13 responses were desirable out of 69, so that a 25% efficacy rate can be achieved. Time period was around 2 years, 2018 to 2020, 70 patients enrolled, 70 evaluable, 75 patients enrolled. Median age was 55.6, 56 patients were post one line, and hypertension and anemia was the major side effects observed. So this is the results they could see. The overall in all evaluable patients, the response rate was only 17.1%. So it was not acceptable, because the investigator wanted around 25%. However, in BRCA germline mutation and somatic mutations, it was 23%. The response rate to olaparib and ceralasertib did not meet pre-specified criteria for efficacy in overall evaluable population. Responses were observed in patients with germline or somatic BRCA mutations. Further studies are needed to establish the role of this combination. Identification of potential biomarkers is desirable. This is one of the last abstracts. Association of research-based HER2-DX signatures with survival in early stage triple-negative breast cancer. So HER2-DX assay is widely known already, is prognosticating early stage HER2-positive breast cancer by integrating tumor and nodal staging and the expression of 3 gene signature tracking immunoglobulin, mediated immunity, proliferation, and luminal differentiation. Investigators assess the prognostic value of each of 3 HER2-DX signatures in early TNBC. So it was around 700 patients were taken from different sets, Metabric and TCGA and GACs, and event-free survival was also seen from CALGB 40603 trial patients. So results were pooled using a random effects model. As you can see, the disease-free survival, the diamond it's significant in TNBC also. If you see the disease-specific survival, the curves are widely separating and it's significant. So IgG immune is prognostic in early TNBC and provide additional prognostic information about beyond TNM. A risk score integrating tumor size, nodal staging, IgG immune might be clinically valuable to help de-escalate systemic therapy in around 1/3 of early TNBCs. These results add to growing evidence that T cell and B cell mediated immunity has relevant prognostic implications in early TNBC. It's a retrospective data. Application in present scenario of NACT is explorable, requires standardization of testing platforms. Thank you.